pick out which medications are in those classes, right? So I would start there. Check on learnings have been posted for all but maybe your diabetes lecture. I think Major Hart told me that she was going to be posting some equations for you to practice from Monday's lecture. Am I tracking correctly? Did she tell you that? I'll check with her and make sure and see if that's happening. If not, I'll post some check on learnings. You always have 2 math questions. You had some math computations that she went over quite a bit on Monday. Should be no surprise that those computations are important, like the 2 different ones that she gave you. So hopefully you understand those. She gave the diabetes lectures, so I will hit them in the review. But all we're talking today is core concepts. Like I said, start with your check on learning. Your memory jogs and your check on learnings, and then branch out. But what I'm going to do is just go by kind of where we started with headaches and move through the different lectures, and I'm just going to make sure that you guys are tracking what the big highlights are as concepts, right? I'm not going to stand up here and give you, here's question number 1 through 50. That's not how it's going to work, right? That's not what it's going to be. So, because you have to own this material, right? You have to pass the test because we test the core concepts, basically. Not a lot of, trivia, at least not what we try to do. So it's stuff you're going to need moving forward. So you can expect the stuff that's important to be important on the PANTS, on your future PA training, on your inter-rotation exams, on your phase 2s, and ultimately in practice. So that's where we're anchoring ourselves. So make sure you understand the core concepts. And we started with headaches, so we'll start there. So migraine, right? We're going to give you, and this is for the entire test, pretty much. If it's a diagnosis that has to be treated with certain medications, then we're going to give you the diagnosis in pharmacology. The ology is when you're expected to have to work through signs and symptoms and pick out, the underlying diagnosis, and then maybe, what kind of special testing or what kind of labs. But in general, we're going to give you the diagnosis if you need that information to answer a Pharm question. Also the labs, right? We're going to, in general, give you the labs and tell you if they're high or low. I.e., if something has kidney dosing, we're going to tell you if their creatinine clearance is high or low, right? So that might be an important concept throughout the test. If when you're working through, you see that, hey, certain medications cannot be used below or not recommended below a creatinine clearance of X. I'd be familiar what those are and then what the other options would be, because we highlighted those in the lectures. But that's as a rule, not specifically for headaches. So for headaches, we'll tell you if it's migraine, if it's tension, right? If it's cluster. I'm going to give you the signs and symptoms, but somewhere in that stem it will say if it's a question that you need the diagnosis to make the Pharm decision, it will give you the diagnosis, right? Now we don't have to give you a diagnosis if we're just talking adverse effects, drug-on-drug interactions, or first-line treatment for whatever. But in general, we're going to give you the diagnosis. So for migraines, make sure you know what agents are abortive, i.e. acute, and then what agents are for prophylaxis. That should stick out pretty easily as you review migraine headaches. If we're looking at new drug classes, it should be no surprise if we talked in Pharm 1 or earlier in this block about certain medications and you understood the mech action, all those things. If we're introducing new stuff that's specific to that disease process, make sure you understand what medications are in that class, what the mech action is of that new medication. Everybody should be tracking what I'm saying. Like if I'm introducing new drugs specific to therapies, know everything about that drug class, right? Because it's new stuff. I don't plan on going back and asking you questions about drug classes that may be adjuncts. Now, we will talk with migraine specifically, prophylactic medications, right, for chronic migraines. Make sure you understand those indications. What would be the indications? How many headaches? How often? Or how long are they lasted per month? To where we would now not only use abortive, but we might start talking about prophylactic. And for migraines, know what those are. In general, for that entire lecture, you should know the acute treatments or the abortive treatments for I got a headache right now, whether that's migraine, cluster, or tension, versus if you meet criteria for prophylaxis, what medications those are, what falls in first line for prophylactic for each of those primary headache classifications. Everybody tracking? Because we have those are important concepts, and they're different, right, between all the drugs. There's some overlapping of how we treat them abortively, and then there is some overlapping of what we can do prophylactically. But make sure you know the indications for prophylaxis and then what they are for the 3 primary headaches that we went over. And know when we would move to an abortive agent. Like for migraines, when do we move to a triptan? When do we move to a triptan? Moderate to severe, we can start right out of the gun. Or if what fails, like non-selective agents like NSAIDs, then we can add them on. Know that concept, right? And then we talked about the triptans being a new drug class, and we also talked about what other agents that we've kind of hit on those agents that are monoclonal antibodies in a few of the lectures, right? So make sure you understand the mech action of those new drugs, what they do and how they're utilized in migraine therapy, acute and abortive. So, and I said, like I said, the indications, how many days per month for all the different primaries, or how many headache days per month. There's a difference there. And also be aware of, what can we use for associated signs and symptoms. You should be able to pick those out pretty clearly for migraine. When you're having nausea and vomiting, what's our first line usually? Should be no surprise for you. Know not only the mech action of new drug classes, but make sure you know the contraindications, especially with headache meds, right? Because if you know the mech action of like triptan, then it should be pretty easy to deduct what those contraindications are. There's an entire slide dedicated to it. So know those, right? Because the mech action causing vasoconstriction, there's underlying diagnoses that would make triptans contraindicated. Also know the big drug-on-drug interactions when we're talking migraine. Because if we go to a specific agent like a triptan, we got to also be careful utilizing other drugs to cause some badness, right? So make sure you're aware of that concept, right? Serotonin syndrome, need to be able to pick out the other agents that if patients in their history on them, can I give them a triptan or not, based on the other medications they're on, and what could go wrong if we did. There's an older drug class that we talked about. Make sure you understand those contraindications. We said they're a drug of the past, but you will have patients on them. So you need to be able to recognize the ergotamines and know which one is considered the most vasoconstrictive, that can cause the most harmful side effects, and the other one's a little bit less, right? So make sure you're still familiar with them, because they still can show up on your pants. And you will still have patients that are successful with ergotamines that will show up into your practice still on an ergotamine. But look at the 2 differences and make sure you understand specifically the actions and the adverse effects, and which one tends to be, cause more adverse effects than the others. Tension was pretty straightforward. Once again, know the indications for prophylactic versus just acute abortive. Also make sure that you understand how long you can be on some of these agents before we start worrying about medication overuse headache for all 3 categories, right? So know the non-specific agents, they're on your slides, should jump out at you. What are the indications for the non-specific? Less than or equal to this many days a month, you can take the medication without a huge concern for medication overuse headache, versus, hey, if we're getting over this, then we're concerned about a medication overuse headache. So make sure you understand by class what the differences are. For cluster, it was pretty straightforward. We talked about the treatment. Make sure you know the treatment. Like I said, we'll give you the diagnosis. And then the prophylaxis. Cluster is kind of unique for prophylaxis, because when do we use prophylaxis for cluster headaches? Anybody remember? During the entire headache. So you can start the prophylaxis while you're having the cluster headache. So it's an important difference there, that you can use the prophylaxis for clusters while they're actually having an acute cluster attack. And once again, know the prophylaxis drug of choice for all 3 primary headaches. Make sure you're tracking the targeted therapy with monoclonal antibodies for for migraines and be able to recognize which ones are migraines, or we have some in thyroid. For thyroid eye disease, we have monoclonal antibodies showing up a few different times on this test. So make sure the MAB suffix works to remember them, but you got to understand the MECAX to know, hey, am I using this in thyroid eye disease? Am I using this in migraines? So make sure you're keeping it separate. Take that extra step, not just MAB. Oh, it's a monoclonal antibody. Okay, which one and where's it being utilized? Because we have 2 or 3 now. We're starting to stack things. All right, let me just look back here. I think that's all I wanted to tell you about the headaches. And like I said, this isn't all-inclusive. I'm just giving you overall concepts. Know your dosing on your triptans. It should be pretty easy. We only have an agent or 2 that you can repeat in an hour, and then we have like an agent that's 4 hours. Everything else is how many hours before you can repeat the dose. So if I understand the 1 hour, there's a couple of them because they're rapid acting, and I understand the 4 hour, then I know what? Everything else is 2, all the other agents. So make sure you're clear on that. Like I said, make sure you pay close to contraindications for the drug classes for headaches. I'm going to come back to diabetes at the end because we're going to do them in the order that we delivered. Which brings us to osteoporosis was next, right? All right. So our first line, what class? Osteoporosis. Bisphosphonates, right? We have our suffix, but we do have an outlier. And know what makes that one different. Know what makes it different. Why is it different? Route. Somebody said it over here. IV for the other room. He said, so yes. Also, what? It's going to increase adherence. Why? Because it's once a year. It's once a year. So make sure you look at the outliers and also can recognize the key dosing instructions for bisphosphonates. They're very specific, and I told you in lecture, boards absolutely love those dosing requirements for bisphosphonates because they're very specific. So get very specific on understanding them. Know what the contraindications to the estrogens are. Right? We only really talked about raloxifene. There was a couple more that we briefly discussed, but really raloxifene. What are we most concerned about with raloxifene or a SERM? VTE, right? So make sure you know the contraindications for the SERMs. And then we talked about the importance of renal dose and considerations, right? So bisphosphonates, can we use those below a creatinine clearance of what? What's the number that we kind of, okay, what, anybody for extra points? What can we use that's a first line? Somebody said it over here, right? So RANKL inhibitors. So make sure you understand those, and not only the indications, but also the contraindications, our adverse effects of the different. We only talked about like 5 drug classes, so make sure you understand those well. There's not a lot of meat on the bone as far as content for osteoporosis. That makes everything in the class pretty important. Everything in that lecture is pretty important because it's very important concepts. There's just only a few drug classes. So I would know those well. Don't take the osteoporosis information for granted because it is highly tested on the boards. And be familiar with the parathyroid hormone concept when we're talking putting in medications, right? So what does continuous parathyroid hormone activity do to bone? Down or up? So when we give an analog like teriparatide, how's it given? Intermittently because it builds bone, right? So make sure you understand that. All right. Make sure you understand or familiar with the dosing requirements or cutoffs for the different drug classes. Some meds we can use 5 to 10 years. Some meds there's one we can only use 2 years, 2 years lifetime. So make sure you understand those dosing considerations for length of using certain drug classes. And once again, pay special attention to the kidney dose and things that are on the slides. So that brings us to, what do we do next? Thyroid? Am I right? I think I'm right. Let's see. Sorry, I don't have it on slides, so I gotta wait on it to scroll down. All right, thyroid, core concepts, right? Drug of choice. All right, levothyroxine. Is that a synthetic analog of T3 or T4? All right, know why. And it's T4 in the other room if you didn't hear what everyone said over here. There are dosing considerations for Synthroid. Make sure you're aware of them, right? And I would know there's a whole slide dedicated to drug-on-drug interactions with absorption of Synthroid. Be familiar with what decreases absorption, what increases clearance. One slide should be, triggering you right now to go to it and look at it and make sure you understand all of those and what agents can cause a drug-on-drug interaction or can increase clearance or in speed breakdown, right, or metabolism of the medication. With most drugs, for elderly and kiddos, do we give them the recommended daily starting dosage? No, right? We start low and go slow in our special populations. That, in general, except for emergent situations, is the rule, right? Start low and go slow with special pops. Got ahead of myself, 1 second. All right, so when we talk about methimazole and PTU, make sure you know the contraindications, the adverse effects of both of them. There's things that are similar, there's things that are different. We have some special times that we use PTU. What's one? Somebody said it already. What's the other one? Thyroid storm, and know why. Why we use it more in thyroid storm, right? So make sure you understand the difference between the two from the same drug class. And once again, the contraindication and adverse effects. Know the monitoring and the the serious adverse effects from that drug class, right? Both of them have pretty much the same one, but I make sure you know, especially if there's a black box warning. That's usually very important information, so we tend to make sure by testing you that you understand it. Know the sequence for thyroid storm and why we're using what. So what does the iodide do? Just know what it does, know why it's used, understand its mech action, right? Whether that be the SKI or the Lugol's. Make sure you know what medications we're talking about, what class they are, and know why they're being utilized in that sequence of thyroid storm, and know where the sequence is, right? There's some very specific indications of when we give what. And we also have some information about if we're going to do an ablation, we have to stop certain classes of medications. So make sure you understand the cutoffs to get your patient's thyroid ready to undergo an ablation or surgery. There's some specific things with some specific timelines. Make sure you understand those. Make sure you look at the extremes of both of the thyroid disorders, i.e. when we get into those life-threatening scenarios for either too low or too high thyroid. Make sure you understand what they look like, and make sure you understand what the treatment is for them. Know how the patient presents and how you would treat it. But once again, I told you we would give you the diagnosis. But there may be some information in there to get you used to pulling out pertinent information like, labs, vitals. That's all to assist you. But if we give you the diagnosis, just be aware of those things. We're not trying to trick you that we told you it was this diagnosis, then we gave you labs for something else, right? So, but they're vignettes, right? You got to get used to, and the juniors can tell you, as you progress, you got to get used to picking out from the vignettes what are important for the question. Because when you get to the pants, there won't be a first order, what's the mechanism of action of this drug, right? It's going to be in a vignette somehow. And then we have another new monoclonal antibody in this lecture. Make sure you understand it, what it's used for, and understand that that medication is utilized just for thyroid eye disease. Even it doesn't really matter what's going on with your thyroid, underlying thyroid issue, so to speak. So even if you got that under control, if your thyroid's controlled and you still have thyroid eye disease, we have some medications that we can give specifically for the thyroid eye disease signs and symptoms, right? Eye irritation or bulging of the eyes. Be able to pull that out of the lineup. Just looking back over my notes here. And I think I mentioned it earlier, but definitely look at pregnancy, what medications we can use and not. Yeah, we talked about it. But know that if we tell you patient has such and such and they're on such and such medications, and if they're having adverse effects, what do we say if you're having adverse effects from medications that we do? Stop them or decrease them, right? Stop them or decrease them. So make sure, logically you think through that. If they have this disease, they're being treated with a medication. Now they have these signs and symptoms. What do I need to do, right? Because especially with thyroid, if we are hypothyroid and start giving medications, we can get over that midline like we talked about, and now you're having signs and symptoms of the other disease, hyperthyroidism. So you would need to look at the medications, either pull them out or decrease them. All right, that's all I got on thyroid. The next was pituitary, correct? That was our oh so fun hour plus on Teams. Me talking to a computer screen, that was great. All right, so for hypothalamus and pituitary, this one, make sure you understand normal. The HPA acts as normal for all of the hormones. You gotta understand normal before you can understand abnormal, or it just gets really confusing. On the test, what would Mercer do? I would probably write it out. Or maybe write that little axis on my scratch sheet. Or you can even do it when we say pass the sheets down. You do you if you want to put it on your scratch sheet. It's all fair. Once we're getting ready to start the test or we say go, put it on there if that helps you. But you have to be able to visualize the normal HPA axis to be able to know abnormal. Because when you start talking like agonist versus antagonist, but then also the process is abnormal or decreased production, the up and down, helpful or harmful, can get really confusing really quickly. So I would spend some time making sure I could draw all of those axes from the hypothalamus down to the target organ, and then what hormone is releasing, and then understanding why if this hormone, if there's a problem here or anywhere up the line, we may not be getting this end product hormone. So that negative feedback loop isn't happening, right? So study habit, make sure you can visualize or draw or write or pull up in your mind the HPA axis for all of the different hormones. It's not a whole lot of lines to learn, but specifically with acromegaly, did we say that surgery was first line, or did we say that medication was first line? Did we say that if we're getting ready for surgery or we failed surgery, there's some medications that we can give to shrink the tumor, if it's a tumor, before we have surgery, or if we failed it? Make sure you know why and the MEC action on those. So for the a prolactinoma or hyperprolactinemia, is that the case, or is it meds first? Make sure you understand that, right? And what they do and what you would give for hyperprolactinemia. The meds, the class, be able to pick them out. I gave you on Canvas a nice sheet with all the different medications in order of how we delivered them in our lecture, saying if they're agonists, antagonists, what they are and what they do, and I underline the suffix on the ones that you can put together. So make sure that you utilize that tool, if you will, to keep clear, because a lot of these medications, these hormones sound alike, right? So make sure you're not just remembering, oh, it's soma something. Okay, we're going to have three choices, right? And they're going to start with soma something. So make sure you're looking at them. Ovulation induction, make sure you understand Some can be, we have that class of medications that can be used, some for males and females, some just males. Make sure you look at that. And then posterior pituitary, oxytocin, know what it's used for. Growth hormone, we talked a bit about, know when we would use it and what agents we would use if there's a deficiency, or as we mentioned with acromegaly, if there's too much. Make sure, and this is where students also, a lot of times will get lost, is in the diabetes insipidus versus SIADH. Like, make sure you understand those concepts, right? The names should help you, right? You should be, oh, it's a syndrome of antidiuretic hormone. So what, if we're having too much of that, what's happening? So you have to understand physiology to really get through the SIADH or SIADH and the DI, right? The diabetes insipidus questions. So know how they're treated, what agents. Make sure you look within classes. Some are more selective for certain type of receptors, and some are more selective for both types of receptors when we start talking the vasopressin receptors. So keep them straight, even within the same class. Like if we start talking about the antagonists, make sure you understand which ones we generally use more often because of their selectivity, right? Versus others that are not as selective, and the vasoconstrictive action could have a worsening outcome or a potential worsening outcome. We talked, and I think we hit on it a few times in the lecture that was in person, I think the first half of this lecture, when we start talking about, once again, intermittent versus continuing doses. Another concept, not only just parathyroid hormone, but when we start talking GnRH, right? When we start talking GnRH and LHRH, when we talk about prostate cancer, and we talk about agonists versus antagonists, which ones have a flare, right? Which one is going to increase, and then it's a down regulation. So make sure you understand and can pick out this medicine is an agonist or an antagonist, and that means we will or will not have a flare when we give it to our patient, which is hugely important when we have things like prostate cancer, where we can start worsening that testosterone initially, causing adverse effects, right? So make sure you keep those separate. Let me just look here, see if I had anything else. Like I said, the big thing for the pituitary is understanding the axes, the axes, and understanding if something goes wrong where, what do we use to either antagonize it or antagonize it, agonize or antagonize, and where in the HPA axis it's working. We talked about a couple of those special agents that were developed to help us in diagnosing our patients or evaluating our patients. There's a couple of slides on it, so make sure you know what's going to happen with the casinotropin stimulation test, right? Versus if you have primary or secondary problems with ACH, right, or ACTH. So make sure that you go back and look at your cortisotropin stim tests and what's going to happen with cortisol based on if the adrenals aren't working, or if they're down-regulated, or if you're normal. So important concept there. Let's see. Okay. So does that bring us to diabetes? All right. So for diabetes, no surprise, you got to know the different classes, right? You got to know the MEC action and when they're utilized. So know metformin, MEC action. Is it considered first line or not? Usually for type 2, metformin. Yeah, right. So once again, we have to know all of those renal dosing considerations. So know for the diabetic medications too, which ones have renal consideration. Does metformin? Yes. Okay. So make sure you're working through those. The bulk of the material from this block was what? Diabetes, right? When you look at by volume, if you look by volume on slides, what was it, 100 and something? Something like that. So make sure you dig in. I know you got that Monday, but make sure you give diabetes the attention that it deserves, because it's hugely testable in the pants and into rotations and out in phase 2. I'm sure tired of hearing that, but we say it because it's important. So yeah, make sure you understand the classes and then what their mechanisms of actions are, right? I won't go through each of those, but all of those main classes, the metformin, the sulfonylureas, the TZDs, the DPP-4s, the GLP-1s, and the SGLT-2s. So I would know the side effects for the different classes and the mech action. Insulin, right? She told you I was listening to the lecturer, so she told you make sure you understand which are long-acting, which ones you're using for bolus and prandial coverage, which ones that you're using as basal, right? So be able to recognize the aspartate, the lispro, and the glulysin as rapid, regular insulin being short-acting, and then NPH being kind of your intermediate. So you got to know when those are used, right? If they're used, at night, or if they're used, only with meals, because I think she mentioned, right, that do you give those postprandial ones if you're not going to eat or if you haven't eaten? No, you don't. And then I mentioned already the calculations. I know she went through those, and it was late in the afternoon Monday, but make sure you go and revisit the calculations that she gave you and the information that was going to be given in the STEM that you need to pull out and be able to put into your algorithm or into your equation. She taught you about the rule of 15, right? If you don't know what I'm talking about, make sure you go look at the rule of 15. Everybody knows what I'm talking about, the carbs and the minutes and what do we do. Make sure you look at that. And like I said, the correction factors, the math. She talked to you about dawn phenomena. Make sure that you not only understand the concept, but if you are looking at blood glucose levels, that you can recognize, is this a dawn phenomenon or not? And what would I do? Or the Samoji effect, and what would I do, right? Your correction factors, important, like I said. And then know how we're splitting our basal or our bolus regimen, right? She talked to you about your total daily, and then how that's broken up, right? How we split it, 50% for basal, 50% bolus. So if you don't understand what I'm talking about, then spend some time with it, right? Because it is a lot of material for diabetes. So make sure you don't just skim over that stuff. So let me go back here and look and see. Like I said, if there's a renal dosing consideration, know those cutoffs for the diabetic agents as well. Adverse effects for all of the different all the different classes of meds for diabetes, and how their mech actions, which could cause certain adverse effects. Make sure you're looking at those and be able to pick them out of a lineup, which meds are in which class. Like I said, the insulin, long-acting versus short-acting, when you use them, important concepts. She gave you some information for insulin administration. Like, make sure you look at those, right? Patient education for insulin is huge, especially when how we're telling our patient they need to be dosing their insulin. There's certain steps that need to be taken, certain things they need to be doing. So make sure that you go back and look at those. Understand some of our medications that our patients may be on with a comorbidity, what that they can affect. Some of our medications can affect our blood glucose, right? She talked to you about a couple. Make sure that you understand those drug classes and what they do to blood glucose, right? Specifically, make sure you're looking at beta blockers. I'm sure she hit that one, in depth, correct? Everybody, okay. So make sure you're understanding that if you have some blood glucose changes rapidly, if there's any new meds added on, what that mech is and why, right? Whether that be increasing our blood glucose or masking it in some way. So make sure you look at those. Like I said, the total daily dose calculations for insulin and the correction doses. Should be no surprise that she spent so much time going through them, and she's going to give you some practice questions on them. And we'll make sure those get out in a timely manner today. I'll reach out to her. She's on leave today, but I'll reach out, and if she hasn't got anything good to go by probably like 1500. I'll post some check on learning, and then probably a couple of the dosing calculations there to practice. So let me go down to just some key takeaways to keep in mind. I hit all the lectures, right? Was there anything I forgot? We don't want to revisit anything from last block? Everybody's good on that? All right. No pain questions? No? All right. No osteoporosis? Or no rheumatoid arthritis, rather. There will be osteoporosis. All right. So let me just talk some key concepts here. So contraindications, make sure you're looking at your contraindications for all the lectures and all the drug classes, right? And so what's going on with this patient? Can we give the drug or not give the drug? Whether that's renal or also knowing some of the adverse effects of the drug classes. Drug-on-drug interactions are pretty big in this block. We only gave you a few, but make sure you're aware of them, right? Make sure you're aware of the drug-on-drug interactions, specifically the things that are going to affect absorption or clearance of a drug that if you don't absorb it properly, then you're not getting the right dose and can have some pretty catastrophic effects if the metabolism and the efficacy of that drug isn't being met because of a drug-on-drug interaction or an absorption problem or a clearing problem or a enzyme problem. Renal dosing, renal dosing, renal dosing throughout these lectures. Make sure you're looking at them. Make sure you understand for the insulins, when we talk about once a day, peaking versus no peaking, make sure you'll be able to put those into certain classifications, right? Because there'll be clues as to which medication we're talking about or which insulin type we're talking about based on if we're telling you there's a peak versus no peak. Calculations, we talked about it. And then always pregnancy and special pops, right? When we start talking cardiac disease, renal disease, the really old or the really young, make sure throughout all the lectures that you're keeping those straight, because there's some special considerations based on comorbidities or age for some of the medications. Okay, so pretty down and dirty. Hopefully utilizing the memory jogs, the check on learning. The check on learning are not clinical vignettes. You're not going to have on this test or in your future tests like, hey, first level, I mean, there may be a couple thrown in there of, hey, what's the mech action of X? So there's going to be vignettes, but those small questions I give on check on learning with the 5 answers, 1 being obviously right, 4 being wrong, make sure you understand when you're going through, if the 4 wrong answers, you're not tracking why they're wrong, that should be leading you back to that topic to dig in. That's why I give you the right and the wrong answers so that you can do your own check on learning, so to speak, and say, I have no idea why it wasn't this. I don't understand this concept. Then you go back. That's why 5 questions can give you, whatever 5 times 5 is, 25, really 25 questions, because in each example, if you don't understand why right is right and wrong is wrong, that's where you need to go back and put some time in. It's a lot of material. Just make sure you're keeping them separate in your mind. And I think if you utilize the memory jogs, the check on learnings, and then what we taught today, just overarching concepts to be aware of. I have no doubt that we're not going to have any issue on this exam, on this test. But just put the time in. You got tonight, tomorrow. And I think everybody will make it through it, and we'll be ready to start block 4 Friday, right after the test. So I will stay around here for specific questions, and then I will come over to the junior classroom afterwards for questions. I don't know if you guys have had a lunch or what you got going next, but talk to your class leader, and I'll be around. Or throughout the week, I do have some other faculty development and things, but my office is right over here on the hallway with most of the other instructors. Past the senior classroom, straight in front of you, not real loud, here to see me in the first cubicle on the right. So I'm available for any questions. Please, if there's concepts that you're struggling with or something that you want to talk to me about, what I won't discuss is specific questions on the test, and I'm not going to say, hey, you really need to study this. What I've said is what is important, right? There's There's no reason for you to come by, and we're not going to have a one-on-one. I'm going to tell you, 50 questions on the upcoming exam. But if you're struggling with concepts, I'm there to assist you with just that, concepts or specific questions. But I think we've given you the ammunition that you need to accomplish this mission on Friday. So good luck.